Hi, everybody. We are here with a panel of excellent folks to talk about some of our favorite topics in healthcare. We're going to be specifically looking at some of the pressures that are coming up that all of these folks are facing. I am Christina Farr. I work for CNBC covering health and technology. And I'm going to let the panelists introduce themselves, starting with Richard.
Good afternoon. I'm Rich Zane. I'm the Chief Innovation Officer for University of Colorado Health.
Angela, you're up.
Hi, I'm Angela Yochem. I'm the Chief Digital Officer for Novant Health.
And Matt?
Hi, I'm Matt Kull. I'm the Chief Information Officer for Cleveland Clinic.
Hey, my name is Alistair Erskine. I'm the Chief Digital Health Officer at Mass General Brigham in Boston.
So I'm going to ask you, definitely the pandemic's on everybody's minds. So I did, kind of want to kick things off by just talking about how your jobs and lives have changed in the past 7 months. I'm assuming that a lot of your work is now being done on Zoom and Teams. And, how has that kind of affected everybody's day-to-day? And maybe we'll just start with Alistair.
Well, things are certainly different than what we would have imagined. I think, it took about a couple of weeks just to accommodate with the various different new virtual technologies that we use every day. It's funny because in our organization, we were undergoing a process of trying to get used to and digitally upskill to Microsoft Teams. And that was no longer necessary within a couple of weeks as everybody quickly digitally upskilled themselves. I think a surprising thing is how efficient we remained, despite the fact that we weren't coming together in our usual sort of sets of meetings that we had on a daily basis. And then how people were able to intercalate their personal lives with their work lives while they remained at home. But I must say, and probably not unique, there's a certain amount of Zoom fatigue. There's a certain amount of having to kind of multitask. And there's a certain number of things that kind of had to be done every day in order to be able to sort of maintain the pace from a sprint to marathon as we kind of went over several different months. The way we functioned under pressure, though, did open up certain opportunities to kind of introduce some innovation and some rapid decision making and some agile thinking in terms of the things that we were doing.
And what has that meant for you, Angela? Have you also got Zoom fatigue, and how are you kind of finding ways around that?
That is an unexpected side effect of the current state of affairs. We were fortunate in that we were completely virtual. We didn't have to roll new tools out, for example, to support a remote workforce, and we didn't have to, rapidly adjust to offer digital health because we had that piece. So it was just a matter of scaling. So we felt pretty good, and we were, feeling like we were responding just as you'd expect, as best as possibly could be. And here we are, 6 months in, and yeah, we're exhausted. I mean, I have a wonderful direct report. Her name is Misty Fragan. She's a VP of Culture and Learning and Research for us. And her team has been extraordinary in finding unique ways to keep us engaged, to keep us constantly adapting and adjusting the way we work together, such that we can maintain the spirit of innovation, the high energy team we've always been. And this may be, something as simple as we're going to take walking meetings because we're going to walk and talk. There's no reason we need to sit here and look at one another, although it's wonderful that we can. There's no reason that we do that for every single one of the 15 meetings a day some of us have, So it's been interesting to watch our culture evolve. And as much as we can do that intentionally, we're able to get ahead of some of that fatigue. But yeah, it's palpable sometimes.
So Matt, Angela just mentioned digital health, obviously a huge buzzword of the moment. I mean, telehealth is sort of being bandied about as the second coming, the panacea to solve all of our problems. Is that what you're kind of finding at this stage of the pandemic, or are you seeing kind of, a real need to, get patients actually back into the healthcare system, back into the in-person environment? And, give us a sense of kind of what you're seeing kind of day to day with probably the mix now of different modalities that you're using.
So certainly on the On the telehealth perspective, I think that's here to stay. And I think that is now going to become the norm, and it's going to allow us to reach more people where they are in ways that they want to be met. I think as we're reactivating our hospital, in Ohio, non-essential surgeries were delayed due to COVID so that we would have availability if in fact there was a surge. As we're reactivating, we're finding that there's a lot of different reasons why folks aren't coming in. And so we've taken a different approach by implementing a CRM package that's actually helping us identify those with the highest acuity needs from a care gap perspective to get those unscheduled procedures back on the books. But it has been really interesting, and tying that together with telehealth has definitely created a whole new playing field for us.
Richard, how do you see this kind of dual kind of landscape as it is currently between telehealth and just trying to get certain patients back to the hospital in person that really need to be there?
Well, I think that there's no such thing as a crisis that does not represent an opportunity. And I think that everybody on this call has had remarkable opportunity over these last few very long months. I'm actually lament that we call it telehealth or virtual health, because it's actual care. It's simply technology-enabled actual care. And our biggest challenge was not actually scaling. We had a very robust virtual health presence. And for us, scaling 8,000% just meant more monitors and chairs. Our big initiative now is really deconstructing these silos of bricks and mortar care, virtual care, synchronous communication, and asynchronous communication, so that one patient is not launched from one modality to another, but really we can blur the lines and take care of patients through all of those modalities, whichever is best for them, and then take incremental patients with that capacity that we've realized. And that's been pretty thrilling to be able to see that.
All right, so I'm going to go across the panel and everybody's got to tell me, is telemedicine overhyped or underhyped? And we'll start with Richard.
Telemedicine is far underhyped. The future of whatever we're going to describe as virtual care is going to revolve around scaling very quickly and very robustly.
Angela?
Yeah, telemedicine is too narrowly defined, and agree that it's underhyped. This is the way in which we reach. Digital health is the way in which we offer access to care in unprecedented ways, not just through entirely digital means, but through digitally enhanced traditional means of care delivery. This is the future in so many ways, all about access, all about quality. And we're just seeing the beginning. We're scratching the surface.
I'm hoping that somebody disagrees and says overhyped. Are you both on the underhyped train as well, Matt and Alistair?
I definitely think underhyped. I think that as we look to partner in our patients' healthcare over a lifetime, we can't expect everyone to stay in Northeast Ohio or Florida or other places we may be looking to expand to. This digital mean is how we're going to be able to take people from the very beginning of their life and until the end. And I think that it's just now becoming clear about the power of some of these tools.
So I'll do my best, Christina, to say that maybe it's overhyped, but I'm going to stretch the analogy a little bit. I mean, virtual is the new black right now, right? So we're at the top of the curve of kind of what we went from like 100 visits to 12,000 visits a day. But we still have to digitally upskill our providers, and we still have to digitally upskill, importantly, our patients, the ones that are not used to navigating across all these new technologies themselves. And we have to worry about payment reform. So right now, it's just, it's hot because it's paid for. In the future, it could not be paid for, and then may slip more into a value-based care arrangement because there's still value. We have to understand what the appropriate use criteria is for virtual compared to in-person and compared to a health bot, for example. And we have to address the healthcare equality issue that emerged as a result of using virtual care, because of the fact that there's a good percentage of the population that just basically can't access that channel. They tend to be the population that is more vulnerable than others, and therefore they're a little bit left behind. So we have to figure out other ways to embed the workflow into our tools like electronic health records, but also embed tools like texting and other ways to be able to get in touch. And we have to be worried about out-of-state care in terms of the laws that you have to abide for when a patient is calling you from out of the state that you practice in. are the laws that apply for that patient. And so long as we stay with a balkanized series of different, local regulations, it's going to be tough when somebody calls you from another state and tries to get virtual care services and can't, or needs to have it modified in terms of being able to take care of it. So
you just mentioned electronic medical records, and that is a nice segue into the next topic that I had in mind, and that topic is info blocking. We, as you may know, interoperability has been a big area of coverage for me, in my work at CNBC, and there was a deadline that was coming up that was November 3rd for this ONC info blocking rule, and now we're hearing that it's being delayed again. But I would like to get everybody's take on how you are preparing for those changes, and how do you kind of feel about that, just the opportunity here to give much more health information to your patients, and what kind of a disruption does that look like for you? And I guess we'll start with Alistair, because you and I have talked about this quite a bit, so I'd love to hear your take on it.
No, so information blocking. So, I think that one of the premises could be that nothing really changes about the patient's inalienable right to their record. What changes is about how patients access it. Now, what we've done so far is we buried the chart in the basement of medical record departments, and we share it in a format with, that includes paper and CD-ROMs. You can't even buy a computer with a CD-ROM player anymore. So we've, at Master and Brigham, we tried something called Open Chart instead of Open Notes, which is, and we've been doing that kind of all along, which basically means a patient can actually ask for their chart electronically, and they can get the response back about their, in terms of a PDF format electronically within 24 hours. Patients love it. When we first started using it, thousands of people were asking for it. But this does require a huge practice change. I think that there are areas that we need to worry about are things like genetic information, like Huntington's disease, that can actually have physical harm if you share that diagnosis. We need to worry about adolescent charts in terms of how do we negotiate patients that are emancipated versus non-emancipated, and is there a way to be able to tease out that automatically? We need to think about sensitive notes like psychiatry, or open notes that were previously blocked and that now would become unblocked, and things called like 42 CFR notes, like substance abuse notes, and how are those shared? And right now our interpretation is they all are. We have to think about, what about an inpatient note versus an outpatient note? As a patient, inpatient is going through that. And then nurses' notes and physical therapy notes are all included in this, which include the full name of the nurses, which sometimes can be concerning for the nurse who's taking care of a patient. And then the final thing, which is probably the one that really we need to wrestle with, is does this include historical notes? Going back as feasibly back as far as we need to, where decisions were made and information was logged in a way that maybe didn't take into account the fact the patient would have immediate access to their chart. All this in the context of the fact that they always had access to their chart by asking for it out of the health information management departments.
Absolutely. Anyone else got kind of info blocking, as sort of one of their main priorities right now, and how are you managing it? Looks like Richard is definitely thinking through this.
So we've been thinking through this a long time, and I think that one of the challenges is really simplistic. It's always easier to say no than it is to say yes, and that's a natural human inclination. So we've started from the opposite direction, is starting off with no and not managing to aberrancy. So everything that Alistair pointed out is a legitimate concern for opening up everything to everybody. But the reality is we are going to open up everything to everybody, and we're going to do it as safely, as thoughtfully as possible. But the reality is that the future requires us to do that. So instead of saying these are all the things that are preventing us from doing it, we are going forward with it, and we will manage those as we go as best as we can, knowing that the national pressure is going to be that this is the right thing to do for patients, the right thing to do for providers. It's simply the right thing to do, and we're just going to move forward.
I think the one thing that I am fully for the sharing of data in a very open manner. The thing that I believe concerns me is the patient initiative third-party sharing. Hospitals are very good at caring for our patients, which also means protecting their health information. I think of my mother, I think of other people on social media or other types of channels where it might not be so clear that the information that they're agreeing to share includes some of their most private health details. And so I think that we're going to have a long time lead up to this of many court battles until this thing is finalized. But I do think that that's going to be an unintended consequence of that. There's potentially some people who will get duped into sharing this information with people with not such benevolent agendas.
Angela, is that something that you worry about as well? The potential here for harm?
Of course, we don't worry so much about how we would share information. It sounds like everyone else here on this panel, that's been sorted for a while now. So it's not a matter of can we share the data, it's a matter of the appropriateness of the share and the potential. I love Matt's phrase, unintended consequence. I think that, some things that weren't mentioned yet, for example, we have an AI-based a cardiac patient readmit predictive model that helps us determine how we treat our patients post-discharge. It's just one of the many inputs. We consider that one of our differentiating elements, one of hundreds. And so wouldn't it be interesting if one of the payers decided to ask us for the detail of that algorithm? I mean, that's, what is the consequence of that? What if the big competitor that we have in any one of our major markets that we support asks us for all of the data for all of our patients because they were able to, through whatever means, get appropriate permissions? Because as mentioned, patients may not necessarily understand what they're agreeing to. So, what are the potential consequences of that from a competitive risk perspective? And these are more of the maybe outlier cases, but it's a great example of how this industry and the regulatory landscape continues to evolve. We have to be prepared not only to respond technically to the requests, but we also need to be able to respond in a way that allows us to have the right conversations with the right entities who are helping make these decisions that will ultimately impact our patients and our ability to treat those patients optimally.
Well, it sounds like there's kind of broad consensus that this is the right path forward, just to open up more information to patients, but that the next few years we're going to have to work through a lot of these, like you said, outlier cases, where there is that potential for misuse. So while we're talking through the regulatory changes that may put, systems like yours under pressure, I did want to bring up, something that's going on politically right now, and that's this debate about the Affordable Care Act and the provision around, pre-existing conditions, something that President Trump was tweeting about even just yesterday. So how do you think through that, as, just from where you sit in the organizations that you work? What do you think, we might see in terms of, the sort of big changes and reforms, depending on, whether we get a new president in the form of Biden or Trump is reelected? And I know this is a big question, but it's very much on my mind. Angela, I'll start with you. Is there a legitimate kind of concern here that we could see patients lose coverage and protections around pre-existing conditions?
Of course, I personally remain concerned about that, but have no particular enhanced insight into the likelihood of this playing out. I'm probably watching this just as anxiously as everyone else to some degree. As far as what we're doing at Novant Health to prepare for a variety of potential futures, we tend to focus on ensuring that we can keep our patient populations as healthy as possible, helping them predict and avoid any sort of major health event, such that there is, such that we can, in as much as we're able to prevent pre-existing conditions from emerging for our patients, that's all we can focus on. Providing easy access, providing, highest quality of care through every means necessary. That's our focus. And of course, we watch with great interest what's unfolding in the rest of the world.
Alistair, any thoughts about what we could see in the coming months?
So it took a long time to wind up the pre-existing condition sets of regulation. It probably will take an equally long time to wind back down if it does go in that direction. And it really is a toss-up at this point. There's been, I think from the delivery side, everybody walks around with pre-existing conditions. Even being born is a pre-existing condition, and so we treat everybody in the same way. I think where it really comes together, where it's supposed to come together, is that we take care of the whole patient, and that the provider from a delivery standpoint and the health plan from a insurance standpoint in this what's called this pay-vider integration really should kind of negotiate how we manage that pre-existing condition. If we're going to talk about value, then the value again comes with the patient and their pre-existing condition. And I think the two can actually coexist. They don't have to necessarily be, a no-sum gain, an all or nothing. I think it makes sense to move the conversation away from like, you had a condition that we're not going to cover, to how do we take care of you and move your care outside of the hospital and the clinic to make it more affordable and to make it more convenient for the patient. How do we manage our referral management so that we can actually get people closer to where you are to take care of you? How to make sure I get you in the right site of care in terms of making sure you're not in the most expensive place where we take care. Maybe those types of approaches obviate some of the need to exclude something which is, part of us as humans in terms of pre-existing conditions, and kind of societally and ethically kind of what we see, as being kind of part of how we have to take care of people.
Matt, so what are some of the tea leaves that you were seeing, with the future? We're talking about single payer, we're talking about, the ACA being replaced with something else. How are you thinking through this? And is there any planning underway at your organization?
I think it probably more now than ever, the future is incredibly uncertain. And I think that, our thought process is much like my two previous colleagues have shared. It's really about maintaining continuity of care and helping patients through their journey, whatever may come. It's going to be an interesting next 24 months, I bet. But I think it'll take a while, as Alistair mentioned, that it's going to take a while to unwind some of the regulation that's been put in place before we see major changes.
Richard, I'm going to shift topics with you a little bit. One of the things that we've chatted a little bit about just, previously here is this issue of patients avoiding care during the pandemic. Back in March, April, we saw studies come out showing that there were fewer people going to the ER for things like heart attacks and strokes. And, the sort of theory being that a lot of folks stayed home, that in fact should have gone in, but there was a fear of being in the hospital environment at that time. So do you have any thoughts about what's coming through fall and winter? Are we going to see a flood of patients coming back in? How are you kind of modeling this out?
Yeah, it's a great question. The answer is it's not exactly an exact science. And what you've seen across the country from modeling is that models get more accurate the closer they are to the event that they're trying to predict. We absolutely saw a decrease in the number of heart attacks, strokes, the things that should be coming to the emergency departments. And we still see late stage of a lot of those diseases. So not a day goes by where we don't see a heart attack that has been hurting for 4 days, or a cardiac arrest that had some mild chest pain 3 days ago. We don't know is the short answer. We could say that there's going to be a higher take up of the flu vaccine and people are going to be wearing masks. So we're not going to see a big flu surge. But if we do see a big flu surge combined with a big COVID surge, it's going to be a conundrum. We also don't know what's going to happen to the previous commentary about access to healthcare, because contrary to, I think, popular belief, when people lack access to health coverage, they do not seek healthcare, and that decreases the presentation in emergency departments. So there are too many confounding variables to really model what the heck is going to happen. But if we have a bad flu season, if COVID continues to spike and surge and people lose access to healthcare, we're going to see a lot of people staying home and dying unnecessarily.
Yeah, absolutely. Does anybody, have a different view here, or is there sort of a broad agreement on that, it's hard to tell, but worst case scenario, we could end up having a fall and winter where a lot of people are sort of suffering and isolated?
I'll jump in and just say that, we're better prepared than we were at the first surge. I mean, that a lot of our processes have gotten hardened compared to when we got hit in March. I think there is another kind of element which has complicated things, is healthcare workers have been called heroes. as they kind of walk into the hospital, just like a firefighter is considered a hero as they walk into a burning building. But that, from a patient perspective, makes it sound like it's heroic to walk to a hospital, which actually can potentially further compound the fear of the hospital. Well, I would suggest the hospital is actually safer than the grocery store, where a lot of people end up going. So I think there's an important piece about saying, to the patients that are around you, this is how we're taking care of things. These are the procedures that we have relative to cleaning. These are the things that we're doing to keep the hospital one of the safest places that you can be. Here's how we're creating a digital waiting room, so you don't actually have to wait in the waiting room. You can wait in your car, you can wait at home, and we'll let you know 5 minutes before your doctor's actually available. And then we need to have, ambulatory situational awareness that goes beyond just waiting for the patients to walk in the door, to make sure that we have a good sense from remote patient monitoring and other ways as to who's getting sick and how to intervene earlier. So I think we're better prepared. We may be unlucky enough to be able to see kind of a really horrific second surge. But I think that better preparedness, the ability to surge up to the units, to be able to put up field hospitals in 7 days like we were before, are things that are going to help mitigate it.
I am far more worried about patients staying home than I am about COVID patients coming and seeking care.
I think we find that it's a lot of education, as patients are reluctant because of the fear of coming to the hospital. But, as was mentioned, it's probably a safer place in the grocery store. And I think there's a lot that we can do around communication about how we're cleaning, about how we're protecting, about how we're making sure that if you choose to wait in your car, that we're enabling you through a mobile alert. So there's a pretty significant educational component of it as well, to just help people feel safe.
Yeah, I actually do want to segue here a little bit to, another issue, which is protecting our vulnerable populations and health inequity in general, because this is something that, obviously we all have been talking about, we know about, but on an intellectual level, but then became very, very real during the pandemic, where we saw, certain groups disproportionately affected by this virus. And, we saw people end up with unexpected bills and that they couldn't afford because they got sick. And I think it exposed a lot of the problematic, sort of underbelly of our healthcare system that, doesn't work for a huge percentage of people in this country. So Angela, I'd love to kind of throw that question to you. Where do we go from here in terms of these inequities that we've been seeing that I think now more than ever we can't hide from?
Well, thank you for that question. In my opinion and in our opinion, we treat the health inequity issue as a crisis that has been ongoing for a very long time. And we have been reacting to it accordingly. So, and I'll give you some examples. I think you've probably seen some of the more traditional ways in which health inequities have been addressed, such as, mobile mammography units and things that allow us to take care to communities that may not otherwise have access to care. And we certainly have those sorts of things as well. But, as it relates to innovation, we are working with a variety of third-party types who are allowing us to, let's talk about mammography just for a second as an example. Who are allowing us to take a look at an image from a mammogram and determine with a very high degree of accuracy the likelihood that patient will develop breast cancer in the next 4 to 5 years. Now, that's not in production yet. We're still doing some very rigorous tests on the but as things stand today, it appears to be a high degree of accuracy. So with that, imagine how that would change how we follow up and how members of the community follow up with their own health and wellness related to breast health, if they have that visibility into the likelihood of their risk for breast cancer. That's one example. There are many other such enhancements to the sorts of to what would traditionally be just traditional healthcare. Stroke patient is another one I'll mention just as an example. So typically a stroke patient shows up, say in a rural hospital, and exhibiting signs of stroke, and they would get whisked back, and a CT scan would be administered, and somehow the radiologist on call would take a look at it and say, this looks like a brain bleed. And then it might go to, the physician on call. And then there might not even be a neurosurgeon on call. Who knows? A neurosurgeon may be somewhere else. But by all this time, the patient's still in the CT scanner, or maybe this patient's out of the CT scanner, and you're trying to figure out how to treat the patient. What we have is we've partnered with a company that allows us to stream in real time the data from the CT scan to an AI-based solution that determines if there's a brain bleed, if there's an operable occlusion, even before the scan is complete. We've pulled patients out of the CT scanner and operated on them within 14 minutes of them showing up at the emergency department. And it's a game changer for, and if you're doing remote surgery, this is a game changer for rural stroke patients. I mean, these are the sorts of inequities that normally would have a significant physical constraint around them, whether you're in an urban area, a rural area, that we can still provide higher level care in scenarios where those inequities would don't need to have that physical constraint associated with them anymore. So we've always, I shouldn't say always, but in recent years, we've had a very strong focus and investment on those sorts of, on closing those gaps, those equity gaps. And that includes things like food pharmacies and, all the other things to address the social determinants of health. So I'm sure all of my colleagues here are also addressing with equal vigor those sorts of things that we know impact the healthiness of our communities.
Yeah, Matt, I'd love to kind of shift to you and hear from you a little bit more about this topic and how you're thinking through it at this time.
Certainly. I'd like to look at it kind of through a different lens of how we're understanding population health as a whole. What are we doing to identify social determinants of health, whether it's transportation, food insecurity, or trying to close the digital divide, and how we can work with community leaders and some of our trustees who are community leaders to put together recycling programs for older technology to enable people to have access to care as well as education, as so much of school right now is being done virtually. And that creates a gap as well, which will perpetuate into a much longer future gap because of those educational limitations. So it's a very important area to focus on, especially given the topology of Cleveland. We have some areas that are very wealthy, and others that certainly require more attention. And so we focus on much of the other technology things that are being mentioned that we are all collectively working on to identify kind of those risk determinants, but also what can we do in the community? That community service is one of our core tenets.
But none of this is new, right?
Yeah.
So this is not new for COVID. It's not new for the pandemic. Social determinants of health have always been predominant in how people present for all manner of illness, whether it's COVID or diabetes or heart attack, and at what stage. So we obviously have failed as a nation in how we've responded, but we've always failed as a nation in how we address social determinants of health and access to healthcare.
Chrissy, one thing that's worth bringing up is some of the vendors produce tools that work only on a smartphone, where the assumption is the patient only speaks English and is technology fluent and doesn't live in a crowded home and has access to broadband internet and can afford broadband internet. But I think it's important to it forces us to have to build another solution alongside of it that addresses the other aspects of making sure that the tools work for everybody, because every patient walks into our door, not just the ones that are endowed with iPhones. And I think building a software with multilingual as its foundation, as opposed to as an afterthought, is a really important thing that we certainly keep pressing on our vendors to say English and Spanish is not enough. Depending upon your community, you may have a whole series of other languages that are going to be necessary. So I think, and as we know, those are the ones that tend to get into trouble because they can't even interpret, what's available because it's not in their language. So I just want to make the case that we think of that from the ground up as opposed to as an afterthought.
Yeah, I mean, you mentioned that you're doing a lot of this work, and oftentimes it doesn't come to you when a vendor pitches you on a solution. They haven't really thought through it. So what would be a message that you would want to share with Silicon Valley at this point, which is, raising all this money for, I think digital health had a record year according to Rock Health in terms of funding, but what percentage of that money is going towards Medicaid populations, other vulnerable populations, thinking through, like you said, the sort of multilingual aspect. And just from where I sit, it seems like a very, very small minority of what you see. So, what messages do you all have? What thoughts do you have for the vendors themselves that are currently raising, boatloads of money to sell tools and solutions to you?
I have an opportunity to advise a number of organizations who are either in the startup community or investors who are building their own portfolios, and it is a tough nut to crack, and it's not because it's because if you're in the business of making money in healthcare, if that is your business, right? If you're not in other words, you're not a philanthropic organization, right? You're not a nonprofit. Your business is making money. So if you're a startup and you've gone to someone and said, I need $20 million because I'm gonna make you a ton of money in healthcare. There's tons of money floating around healthcare. I'm gonna go get it for you. Where are the buckets of money they're gonna go after? There is share of the consumer wallet, right? How much money would I be willing to spend for yet another health wellness app on my phone? I probably have 20 on my phone right now. Like, how much more money a month would I spend for yet another one? There's share of the consumer wallet. There's, the direct to consumer sort of model. And then there's, healthcare systems like ours will of course pay for, in the traditional sense, for services that we can incorporate into our ecosystem. And then, there's the payer community who would like to see their healthcare costs go down. And lastly, it's the self-insured employers. What can you sell? What can you build to help self-insured employers manage those healthcare costs out of their operational expense on a yearly basis? And so I think when you're in the startup community, it serves you well to be very clear about which one or which ones of those buckets of money are you going after? And then you have to ask yourself, if you're a mission-based organization, how are you best going to take the talents and the unique tool sets that you have that will allow you to not only make money and pay your investors back and make everybody happy, but make the world a better place? That's why this is difficult. These are big, tough questions. So excellent question, because that's, I think it's that broader ecosystem that's really going to change, allow us to change and make rapid and lasting change in the healthcare space.
Anyone else got any thoughts for the vendors?
I think that the question is a difficult one, right? There's a lot of conflicting interests between healthcare technology and the providing of healthcare. But I will say that I think we all are very cost conscious as reimbursement rates continue to shrink, as those margins tend to erode over time from the payers. Because as Angela said, all of the payers are looking to reduce their costs. The plan sponsors, the same thing. And I think that those vendors really need to look beyond the latest, greatest kind of shiny object and into what does it do to the entire kind of continuum of patient care within a health institution like Cleveland Clinic or one of our other hospitals, because those dollars are starting to get, the technology is starting to get unbelievably expensive. And I think vendors need to really kind of focus on that value proposition. And to your point, it has to be the value proposition for all patients, because the high reimbursement rate patients need the same care that everyone else across a continuum needs. So that value look and the cost of some of these technologies is tough. It is a really difficult question.
I'm just curious.
Healthcare cannot be the last bastion of industry where adding technology increases cost and complexity.
Yeah.
I'm curious from all of you, maybe we'll start with Richard. How many pitches do you get like every single, say, week from some startup trying to sell to you? And has that increased in the past 5 years or so?
If you include emails to me, submissions to our website, to my team, to the larger team, I think it's one pitch every 17 to 18 seconds.
Oh my God.
Really, I mean, it's just colossal number of vendors and or collaborators that are really approaching us. And if you add people who are looking for investments, then maybe every 2 seconds.
Chrissy, I have a bot that goes through my email and takes them out.
Alistair, can you share that, please?
Yes.
Please,
We all want that bot.
yeah, please. Thank you.
So are there terms that your like bot is screening for? Like as soon as you see AI, it just like immediately deletes it?
There are terms literally that you can find consistently in emails that pitch, and it basically puts it in a folder that makes sure that it separates out, the things that I need to pay attention to against the things that I can maybe review slightly faster.
Mine is any email that starts with Dear Richard.
The thing is, anyone who, if our tech scouting capability was reliant upon what lands in my email box, we might as well go back 20 years ago, right? I mean, all of us have robust tech scouting capabilities out there. We have people plugged into all different sorts of, all different parts of the broader ecosystem. If chances are before you send us an email, we already know about your company and we already know about your offering, or we heard about it being funded. And, we either reached out to you already or we didn't. So it's really tough when people are trying to come in cold and get our attention. We have mechanisms in place for that sort of tech scouting. It's already,
Would you rather an email where someone said, Angela, I just want to shadow you and learn from you?
Yeah, actually, I'm a sucker for those. But at this point, I've stopped. I've even stopped with that because, I think I may have mentioned 15 to 20 meetings a day earlier in the call. And so the laws of physics have prevented me from taking on any more of those as well.
So I guess at this juncture, I'd love to talk to you guys about kind of low tech versus high tech, because on the one hand, we're all, you guys are all dealing with fax machines, pages, like some of the most outdated technology. Somebody jokes with me recently that, these technologies were only ever used by drug dealers and health systems in the past few years, but apparently now because of some of these anonymous apps for messaging like Signal, the drug dealers have moved on. So it's really just you healthcare folks that are still using fax machines. So, how do you kind of like hear about all this AI that's going to revolutionize healthcare on the one hand, and on the other hand, it's some of working with medical record technology that's based on, infrastructure that was built in like the 80s. So let's talk about that. How, like, what's the right kind of blend of different high and low tech? And I guess we'll start with Alistair.
So it's a great question because, we're thinking about how do you take the provider schedule and optimize it using machine learning about what happened over the past year and getting the right patient into that schedule. But you got to make sure you answer the phone when the patient calls. So there's this real tension between kind of the innovation and the next thing to do versus kind of the operations and what do we need to fix now. It's more attractive to go after the high tech thing. Sometimes it's more important to go after the low tech thing. And so oftentimes our aspirations are mollified by the fact that we need to fix our low tech so we can sit on the shoulders of that as we bring the high tech along the way.
Richard?
I still like quills and faxes. I think that's really the answer. For me, I'm hyper pragmatic and I need partners that are going to be pragmatic as well and understand that although we've got this wonderful data architecture, there's still a lot of stuff that may be on paper or Alistair's CD-ROMs.
I had a fun story a few years ago about medical students that, were in their kind of first days of programs, internship programs, and they couldn't use the fax machine. They didn't know how to explain it, that they couldn't use it, which is pretty funny. But I mean, it just goes to show kind of, sort of the environment that we're in. Matt, any other thoughts on that low tech, high tech divide?
No, I think that there's always an analysis about how much the change is actually going to cost. We talk about pagers. There's always that one spot in the bottom of the basement that doesn't have cell coverage. And so we're still hanging on to pagers because the cost of getting that coverage down in that area far exceeds whatever the pagers are costing us. So change is expensive sometimes and sometimes not worth the cost.
So we're going into our final minutes here. The topic is innovation under pressure. And so just maybe leave us with one remaining thought. What is the thing that keeps you up at night? Keep it to a sentence or less. Alistair?
Trying to hold on to the speed with which we're making decisions and the amount of innovative, rapid, iterative things that we put into the workflow with COVID into the future.
Angela?
Yeah, I'm kept up at night thinking about the exciting things that we can now do as technology advances and as medicine continues to advance. The intersection of those two things, best thing in the world to be doing.
Matt?
There is unlimited, infinity amount of technology available to do innovative things. And I kind of get kept up at night when we're not laser focused on a couple of really important things and we're trying to do everything at once. I think Alistair got it right. The speed at which we're trying to innovate is a little cautious.
Last one.
Innovation requires people, process, and tools, and people have to be tolerant of failure and tolerant of change. And I stay up at night and worried about fatigue for tolerance and change.
Yeah.
Well, thanks. On that note, we are about out of time. So really appreciate everybody's energy this morning. I think we had a great conversation, and hopefully we'll do this again.
Thank you.
Thank you.